Hello, and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the WSLD. I'm Joseph Lim, a professor of medicine at the Yale School of Medicine in the section of digestive diseases, and I'm pleased to welcome you to our series here in which we're going to be asking our colleague, Dr. Gautham Reddy at the University of Chicago, to describe his recently published paper, Impending Hepatology Workforce Shortage, Ethical Considerations for Closing the Gap. And so welcome, Dr. Reddy, to this discussion. I would love to be able to ask you to just start out by describing this paper, what led you to addressing this issue in CLD, and just want to ask a few questions about what you learned.
Sounds great. Thanks for having me, Dr. Lim.
Absolutely. So I guess, first of all, I'd want to ask, why is there a shortage in the hepatology workforce?
Oh, that's a great question. So in 2020, the ASLD commissioned what's essentially a workforce study, which was a paper designed to look and see where we are with, do we have the right number of hepatologists? Are they geographically where they need to be? And it turns out that there's a 35% adult FTE shortage that would be predicted by 2033, and 19% in the pediatric population. And there's several reasons. I mean, some of it is just a rising disease burden. I think we all see in our clinic more MASLD, a lot more alcohol-related liver disease. Also, the U.S. population is getting significantly older. And then something we don't think a lot about is the actual aging physician population plays a big part of it. And this is really a broader issue in the United States. And it turns out that anywhere from 40 to 120,000 physicians will be short by that many in the next 10 years. And this especially gets exacerbated in the rural United States.
Well, that's very interesting, and obviously has implications for patient care and for our training requirements within our specialty societies. So along these lines, do you believe our current system for training the hepatology workforce is adequate to meet the population needs?
Yeah. So it turns out that there's significant outcome differences when you look at a bunch of different populations. For example, patients who need transplant from rural areas will do significantly worse than people from urban areas. And then beyond geography, outcomes are affected, whether it be just viral hepatitis, MASLD, alcohol-related liver disease, based on your ethnicity, your education level, and also sort of geography has an interplay there. Our current training for hepatologists is very transplant-oriented, which really leaves us with more physicians that are interested in being in urban locations. I think it attracts people like that. But there's a lot of liver disease out there that is, for patients that don't have access to transplant centers. And interestingly, through this exploration, it turns out that the graduate medical education machinery in the United States is really not set up to right-size the number of types of doctors we need, either by disease process or by geography. And that leads to a lot of sort of ethical issues. I think some of the sort of pushback has been, well, gastroenterologists should be doing more, but gastroenterologists are a lot busier now, just like hepatologists. They not only have the screening guidelines changed, but GI diseases have become a lot more complicated to sort of care for as more therapies have come out for IBD or irritable bowel syndrome or esophageal EOE, other diseases like that.
Absolutely. This obviously has great importance, and I guess that leads to the natural question: what are some of the remedies or things that can be done to improve access to hepatology care in the future?
So I think the underlying answer is going to be education, and the question is who and how do we sort of get that education out? I think probably a multi-pronged approach. I think fellowship training right now, it's targeted at transplant. we have about 10,000, people being transplanted a year. The question is, do we need 50 or 60 transplant hepatologists coming out a year to take care of those? I think the other piece of that is most transplant hepatologists will also say, and the workforce study, sort of will bear this out before, that even people who identify as a transplant hepatologist see more general hepatology than anything else. And I think most people realize that we do see a lot of advanced hepatology. And so one of the things that's been proposed is, should we change training to advanced hepatology and transplant hepatology, similar to the cardiologist? I mean, I think there would be more interest in developing community hepatologists if we sort of said, well, you could go out and be a hepatologist in the community. Maybe you do a lot of endoscopy, but your clinic time is taking care of liver patients. And I think that would expand access for patients. That does require some changing in terms of how we train people and write the exam and what training programs need to do to get their fellows ready. But I think that's something that's reasonably achievable. A couple of the other things that have been talked about, there's this concept that's new. I think we'll be hearing a lot more about it, preventive hepatology. And that really is engaging non-hepatologists and non-gastroenterologists in liver care. So that would be teaching people in the community to sort of recognize risk factors for MASLD, learn how to use non-invasive markers of fibrosis, recognizing alcohol-related liver disease before it becomes a problem, when it's just alcohol use disorder, and getting those things treated, learning how to look for and treat viral hepatitis like hepatitis B, hepatitis C. We've seen a push, particularly in hepatitis C, in the last 10 years. And those things can be expanded, and there's lots of ways to do that. And then finally, I think we are not going to be able to train enough physicians to do all this. I think it's not just liver. I think a lot of disease processes and a lot of fields are going to have big shortages. But the question is, how do we get advanced practice providers more engaged? And I think reaching out to APPs to get them trained in areas beyond transplant centers. So reaching out to community gastroenterologists, maybe endocrine practices or community internal medicine practice, to get them involved. In the past, the AASLD has done the emerging liver scholars for resident physicians and APPs that are at transplant centers, but could that model be used beyond transplant centers for APPs?
Oh, wow. So this is an incredibly important issue that will require multi-stakeholder engagement to really begin to address this issue in a way that's going to be really mindful of improving patient care, population health, in context of our current structure for providing liver care. So thank you, Dr. Reddy, for sharing your paper here in CLD. For those who are interested in learning more, I encourage you to go online to CLD to read the full paper. And I want to thank all of you for joining us for another installment in the CLD video series.
Great. Thank you very much for having me, Dr. Lim.